honor to be sitting in between one past president of the IPEG and one potential president of the IPEG, Holger Tail and Mac Hammond. Please, Mac.
Thank you. With no further ado, we're going to welcome Dr. David Sigalet from Sidra Medical and Research Center in Qatar. He's going to talk about MIS and chest wall deformities. Thank you, David.
Thank you very much. I'm delighted to be here, and I echo the comments of my previous speakers. It's been a delight to be in Egypt. It's my first time with my wife, and we are enjoying every part of it. It's been wonderful. But I think that I'm not sure of how many people in the audience are doing the NUS procedure, how common chest wall deformities are in this area. I must say, since I moved to Qatar, I have not seen as many as I used to see back in Canada. But we have to have disclosure that we're mostly doing things that are not part of the normal indicated use of the NUS bar. But I believe that as we develop more of these techniques, there will undoubtedly be patients that show up to your practice. And I want to give you some tools about how to use the NUS procedure in different situations, how to evaluate the patients, and some of the lessons we've learned about using ancillary bracing. I think it's very helpful to have that option for these patients. First, a word maybe for the more junior colleagues about the pathophysiology. This is still quite controversial, but it's becoming clear that there are not only the form, but also the biology of the cartilage is not normal in these patients. And it is not an overgrowth. Some of the previous literature suggested that it was the fact you get either indentation or protrusion is because the cartilage segment is growing too much. But in fact, that's not the case. They are not longer than normal cartilage, but they are weaker. They are structurally not as strong as regular cartilage, and they are in some ways actually brittle. So the current theory is perhaps the flexing of this area here during breathing is what causes it to either push in or push out. I've seen many patients where one brother has a depression and the other brother has a protrusion. So there's something very deeply flawed in the structure of those cartilages. But whatever the problem is, if we have a patient, we have to evaluate them. And I put this in because some people have not seen this measurement tool called the correction index. Again, we've mentioned several times today the group from Kansas City and Sean St. Paul, and they are Sean St. Peter. They are very innovative, and they instead of using the Holler index, which most of us are familiar with, the transverse diameter over the correction, they notice that especially if the transverse diameter is not that large, then the Holler index can be misleading. So they suggest to use this correction index where you take the total expected distance to the sternum, subtract the actual distance, and then have that as a ratio. And so in a patient like this, the correction index is actually about 20, whereas the Holler index is actually not that bad. So it's a better representation. And also, if you use it right, will work for these more unusual configurations as well. So if you start to see a lot of patients, I would recommend that you spend the time to become used to this measurement tool. The other thing you'll notice is that we did a CT scan. So that was our protocol, that we do a limited CT at the deepest portion of the defect. One shot takes 1 minute, and that way we get a really good understanding of the anatomy. You can imagine this patient, the heart here completely pushed up against the sternum. You know you have to be careful when you're doing that dissection. The other thing that I think will soon be available is the use of non-radiological measures. So we have the option of optical imaging. This is a setup we had back in Canada which is quite a complicated setup. The very interesting thing is there's now a handheld version of this from this company, Polymus. You make a reference point, and then you just run the scanner up and down the chest, and it will give you a very similar contour, so that if you're if you have children and you're following them, just trying to decide when to operate, you can use this as a way of actually measuring the changes and make your decision based on fact. The other thing I would recommend is that there's a company developing basically a flex meter. The problem in the OR is when you get in and you're trying to push the sternum out, especially if the child is a little older, 14, 15-year-old, I'll show you in a minute, it can be physically very, very rigid and very tough. And it alters what you do in the OR. It also makes the safety a consideration. However, in the younger children, it's almost always more flexible. And so if you can measure the flexibility beforehand, you can get an idea of how this will be. So I put this on your radar as a future tool for how we might deal with these patients. So after moving past the evaluation, I think most of us are fairly familiar with the approach to a nice symmetrical defect like this. We put in the NUS bar. Most of us use a scope to dissect underneath the sternum. I think we all should. And then we will, in our situation, we would typically use my finger on the left side to push the heart away, pass the dissector across, get our bar in position, and flip it. And that works well for a young patient in the 12-year-old age group. The chest pops up nicely, and you have a good cosmetic result. But as I said, it's much more difficult in the patient as they get a little older, and the biggest issue is pain. The other thing I'll point out is that NUS group themselves have had several patients with epidurals have significant neurological deficits after the procedure. So most of us have switched away from using epidurals in this and just using patient-controlled narcotic. But there probably is a way surgically that we can help. So we began several years ago to make relaxing incisions in the cartilage, and you can, depending on how rigid the chest is, you can make them on each side multiple, and they do make a significant difference. They are very easy to do with either just a regular cautery with the tip bent or the L hook, and this is new data that we accumulated over the last several years, where we actually measured the pressure it took to bring the sternum up to neutral before we put the bar in. And we measured it initially, and then when we did the relaxing incisions, we had a significant drop in the force that we required. We also could note a significant drop in the days in hospital. However, I have to admit that these ones without relaxing incisions were done significantly earlier in our experience, and we became much more aggressive in pushing the patients out the door as we became more comfortable. So that I would recommend the use of the relaxing incisions in any case where the sternum is difficult to bring up. The other thing we began doing as well is actually starting to make incisions in the bone. We had one small orthopedic dissector we could use to either with a hammer to crack the bone, and then there's one burr hole type device with the Midas Rex you can use as well in really difficult cases. So we would use those. I'm missing a slide. I'll go. In these types of cases where we have very, very asymmetric defect, we actually would crack the bone in each side and do a limited ravage, and then put the bar in to get that across. So I think that's as you get more experience, the options that are available. The other types of patients we would get as we started to do pectus excavatum is these patients with carinatum. And again, if you get into this, I think it's very helpful to develop a relationship with the orthotics folks in your hospital, because I wouldn't have believed it, but a case like this, you can correct with bracing. In Calgary developed this custom-made brace where the patient can control the pressure using this small ratchet here, but now there's a commercially available one which is pre-made, significantly cheaper and much more versatile. Just to show, you can correct these in about 6 months in the majority of cases. The most important thing is to encourage the boys to keep wearing, and they're typically boys, to keep wearing it until they actually go through the growth spurt of puberty, because then the chest wall becomes completely rigid and maintains its final shape. But if you haven't seen it in 6 months, this boy goes from a huge defect to being essentially normal. It's a very gratifying, however, non-surgical option. I guess that's completely minimally invasive. The last problem I'll talk about is we often would have the case we put the bar in and we end up with this flaring of the ribs here, and that would become the issue. So with a more moderate case like this, we would put them on an exercise program. If it was more severe, we would actually brace them for 6 months afterwards, and it worked very well. So you have, you know, a brace on the inside here and an external brace compressing on the outside. So in the future, I think there are going to be more and more develops in this area. There's imaging and ability to do some modeling of the bar placement. There are several companies very active in developing this technology. There continues to be interest in some cases of the use of the suction cup. I think that's good for surgeons to know about, because what happens, they start with the suction cup and they get bored, and then they'll come to have the operation. And then most of us know about Mike Harrison and his efforts to put a magnet underneath. We'll see where that goes. So all in all, I think that this is an area where as technology improves for our minimally invasive approaches, there will be more and more of these patients who will be coming to see us. With a little bit of help from your team in terms of the orthotics people, imaging people, I think we can make a very good program for them. Thank you very much. I'm happy to answer a few questions.
Thank you, Dr. Sigalet. That was a very nice review. We have time for one short question, perhaps. David, a quick comment about 2 bars or 3 bars.
I became, over time, my personal series is about 180 cases now. Much more likely to put in 2 bars if I wasn't happy with it. If they don't look really good here at the end of the case, especially with a long, sort of valley-like defect, I would put 2 bars in.
They don't look better a month later.
No, they don't. They look worse only after the operation.
Well, thank you very much.
Can I just see hands up? How many centers here are doing it or are considering doing NUS procedures for chest wall? A few, yeah. I honestly, I don't think there's so many in the regional population, but also I think it also depends on some cultural issues. You know, the young guys out in their sports clothes playing sports, so they're the ones that want to get this operation done. Thank you.
Thank you, Dr. Sigalet.
Yeah, the next talk comes from Philippe Savay from Zurich and from Switzerland again, Lucerne. We'll come back to the topic of TEF and EA repair thoracoscopically and move to the most advanced ones. Philip, you are, I think, very designated to talk about long gaps. What's the place of thoracoscopy?
Olga, thank you. Mac, Sharif, thank you very much. I would like to express my thanks to Jamal El-Taghi, to Ayed Al-Katani, and also to Samir Shayata, who have been inviting me here for the second time. And it's a pleasure to be here. And I hope I can make my talk in time, so why we lose time. From antique to present, there were several milestones in minimal invasive surgery. The old Greeks started to kind of try to look into patients or persons. Then the invention of the Harold Hopkins optic, which was a major milestone in providing adequate picture with a videoscope. In 53, the last century, was a major invention. And then Philippe Mouret, he started to doing the first laparoscopic cholecystectomy. And at that time, very remarkable, the German Society of Surgery considered this to be Mickey Mouse surgery, so they would never do it. So no doubt that they, as to cite Mantra, will eat their head today. So the history of minimally invasive pediatric surgery, especially the for thoracoscopic esophageal atresia, is a little bit connected to German history. November 9, 89, the Berlin Wall came down. The same weekend, there was a meeting on pediatric laparoscopic surgery and laser medicine that was put together at that time, and there was a first report on a laparoscopic appendectomy by Jeff Vallat from Nice. And exactly 10 years later, I have to correct Mantra, it was in 1999, not in 2000, Doctors Loeb and Rottenberg, by occasion, did on the same meeting the first repair of esophageal atresia without a tracheoesophageal fistula, however, but this was a surgical first. So in looking at what has been published, this pretty nicely explains where we are now from a surgical first back in 1999, the way to go, lessons learned, updates, and today long gaps. That's where we are right now. It has been a remarkable evolution of technique to look what I was arguing for this morning without being convinced, from open surgery to the thoracoscopic way. And if you see and look at that, this is the fistula, this is the anastomosis not yet completed, the NG tube in, and this is augmented vision through thoracoscopy. So this is very convincing and how I could take a look at. There is evidence for minimal invasive surgery for TF and esophageal atresia, meanwhile, with providing similar outcomes, similar leaking rates, and even a higher stricture rates with open repair, maybe, or it might be due to a more rough suturing technique, because I can't see it so exactly. So this has been the change of approaches in my former institution and now in Switzerland, where we started in 2003. We had to convert the first 8 cases because we just didn't get along with anesthesia. There was lung lacerations, we had no sight, we couldn't do anything above 2 minutes continuously, so we had to convert. And then when we started taking advice from other people who has been doing that at that time, it suddenly worked, and ever since we had to convert. I mentioned it this morning, we did take a look at perioperative outcomes in terms of anticipating what pediatric intensivists as well as anesthesiologists were arguing for. The children are doing worse after thoracoscopic surgery, and we could prove the opposite. However, in terms of comparing the intraoperatively CO2 values, there was obviously an increased PCO2 during thoracoscopy. However, this decreased postoperatively, and the time on ventilation at that time was significantly lower for 1 day compared to the open group. This is just a regular case, newborn, 35 weeks of gestation. You see the typical appearance in the thoracic X-ray pre-op, and you see here the thorax drain, the pleural drain, and the NG tube, which is going down through it after the operation. This is the fistula. I always tend to clamp it and to make sure it is the fistula. I already did also dissecting the main bronchus or the main trachea. This is the upper pouch. This is the NG tube, and this is the almost finished anastomosis, and this is the final appearance. So the first thing is, in comparison to Derek, who showed you that he never dissecting the azygous vein, I always do it because it provides me a better view onto where the fistula is. It's a landmark for the fistula. In this case, we used a very modern 3mm sealing device, which is probably a waste of money for this case, but we wanted to kind of try it out, and dissected the azygous vein with this. Then the major goal in the very first beginning is to find the fistula. Here you see nicely the vagal nerve preserved, the fistula dissected. This is the trachea. And then I do always use transfixing sutures to kind of take care for the fistula. I do not use clips. The only recurrence of a fistula was when we used a clip, and we kind of safely secure the fistula. You see this later on again. There are some tricks and pitfalls. I would rather recommend, especially when you begin this technique, to clamp it to confirm the right structure when you see and identify the fistula, to always try to preserve the vagal nerve. Keep some distance to the trachea, and while ligating it, you don't want to compromise the trachea. And when dissecting, do not cut completely. It will go down all the way, and you have maybe troubles finding it back again to do the anastomosis. So we cut it half the way, we put the first suture, and then we cut it completely. And always in doubt, consider bronchoscopy. And I do, meanwhile, placing the first suture with the still closed upper pouch in order to help the anesthesia pushing with the NG tube the pouch down, so it helps approximating the both parts of the esophagus. So sometimes it's hard to identify the fistula. I want you to mention that this is a lobus venae azygos type in a very small kit with 1600 grams. So the azygos is draining into the right lobe. It's not the normal situation here, the regular situation. So I try to a little bit harder to identify the fistula. We are working here on the upper pouch. And while we had an anesthesiologist who was so nice and kind to provide us with a Fogarty catheter in the fistula, put in with bronchoscopy, it was very nice and easy. And you see now he's pulling the Fogarty back. We can clamp the fistula and make sure that is the fistula, and then we can provide it with a transfixing suture. And here, the vagal nerve. This might be also helpful when you have the azygos vein, which is ligated here. This is the one stump of the azygos vein. And again, the Fogarty really nicely demonstrates where you are. And now pulling it back, you see the movement here when the Fogarty has been pulled back. I'm really sure that is the fistula. It helps you. It's assuring you during operation. It makes you more safe and feeling more comfortable. You don't have to do this necessarily. This is a case where we identified the fistula very easily without using a Fogarty. This is again the azygos vein, also transfixed and sutured. And then you can put the fistula down. Oh, I always clamp it meanwhile. And in doubt, use bronchoscopy. So this is an intraoperative bronchoscopy in a child where we hardly could find the fistula. And then with bronchoscopy, we could identify it, see the light from thoracoscopy. And I think we put later a Fogarty in to really make sure. And you see down here, this is the bifurcation, and here's the fistula. It might get a little bit closer. This is the picture of it. And you see here the large opening of the tracheoesophageal fistula. So dissecting the fistula, be safe. So that's why I use transfixing sutures, undergoing the fistula, then transfixing it, and intracorporally knotting it. I really want to sleep well when I go home at night and not being kind of insecure about a clip or something which might dislocate, or even just a ligation. However, in experienced hands, like Darek has showed and proven, this might do the same job. So the second goal is then identify the upper pouch and mobilize it as far as you need it. There's no need to do a complete dissection. We talked about this for hiatal hernia. The recurrence rate in those cases is much higher when you do an extensive dissection. So I do think that the vitality of the anastomosis might be compromised if you do an extensive dissection. However, you want to have a little bit of a moving range with your upper pouch. So this is a technique which I don't want to show you because we don't do it anymore. For the anastomosis, I really ask the anesthetist to push down the NG tube while the pouch is still closed, put a or full thickness layer suture through it, connect it with the fistula for the first suture, and then open it and cut the fistula, and then do the rest of the anastomosis. Another technique, as Derek showed you, is the sliding knot, where you can easily adapt the two parts of the esophagus. So this is demobilization of the upper pouch. The hardest part is the membranous part between the esophagus and the trachea. When you do extensive dissection here, you might have the risk of ending up with severe tracheomalacia. I come back to this later. So I use very low energy with the hook, or I do sharp or blunt dissection here with the scissors. But again, augmentation is nice, and you can really perfectly identify your structure and the layers. So then the transanestomatic tube is put in. Please mention that the first suture is already put, already set. So then you put the NG tube through it, and then you can easily, with the help of the NG tube, which is kind of expanding the anastomotic parts, you can easily finish the anastomosis. And then at the end, you prove it having a tight, watertight, and not so suspended anastomosis in order to provide good healing. You see this again just for proving that this was also possible in this very little child with the azygous vein draining into the right lobe. This is the completed anastomosis. So we do regularly, we do a contrast study 10 days post-operatively. This is a result which we expect to have. Then we put out the NG tube and put the baby on full enteral feedings, step by step. And why do we do this? Because this is 4 weeks after the first case we did in Lucerne. You can identify the trocar positions right here below the right mamilla, one here down paravertebrally. This is from the thorax drain, and this is the scope. So the problem is the long gap atresias. See here, this was the first picture of a child with a long gap with no fistula, 6 centimeters in distance.
You have 3 minutes, please, Philip. Okay.
Huh?
3 minutes extra.
Okay. I will do it. I sent those pictures to Steve and asked him what to do, and he said, "Well, just go in." So we did. The upper pouch was nicely reaching up to the azygous vein. The lower pouch, we couldn't find it all, so we had to open the diaphragm and then identify it. So what we could achieve in this case in the first attempt was to approximate those parts up to 1.5 centimeters. Then we did another contrast study 4 weeks post-operatively, could identify the gap of still 2.5 centimeters, went back in. This is the laparoscopic view of dissecting the hiatus. Then we could identify the stay suture, put it away, and put those parts together and achieve a primary anastomosis. The X-ray after it was not looking so nice, but it did the job. So when I am allowed to cite Steve, I would still go for any case of a long gap atresia in thoracoscopically, not until we proved that an anastomosis could not be achieved thoracoscopically. The problem is the strictures. This was the same child 4 weeks post-op. This is right after pneumatic dilatation. So it's a long and winding road with the long gaps. I want to go over the aortopexy, which might be interesting in a sequentially thoracoscopic procedure. But to answer the question from this morning, the time for personal learning curves, which we were allowed 10 or 15 years ago, is over. So see one, do one, teach one is not adequate anymore in those children. But see one, practice on a simulator, and then do one might be the new mantra of the pediatric surgeon who wants to do that. So thoracoscopic repair of TF can be nicely simulated in 3-dimensional models. Those pictures, I have the pleasure to have them from Kathy Barsness in Chicago. 3D printing models took from MRI or CT scans provide models which are simulating the technical aspects of the operation. You put those into a simulator. This is not a baby, it's a plastic simulator, and you cover it with silicone skin, and you can do the operation step by step. The next step would be to implement animal tissue, which is simulating a TEF and esophageal atresia beside other pathologies, and to replicate the procedure. And then you go into, maybe you might go into live animals. This is a rabbit workshop which we did to kind of train people on doing thoracoscopic TEF repairs, and she expects us to do it right. So this is the reason we have to train ourselves before we go in. Last slide, or almost the last slide, save the date. This is IPEG next year in London, and with my greetings from Switzerland to wonderful Egypt, I thank you all. This was yesterday in the desert. This is the Egyptian team I had the pleasure to work here with. This is the Red Sea, which is beautiful, and I really enjoy to be here. It's a privilege. Thank you.
Thank you, Philip, for your nice presentation with the end part that the high fidelity simulator should be part of the education and training. The floor is ready for 2 short questions, please. Okay.
Mentioned about using a so you mentioned about using a Fogarty catheter for identifying the fistula. Can you just describe this a little bit more? About using the Fogarty catheter to identify the fistula. Can you just describe that a little bit more, mentioning the size of the catheter that you use?
The Fogarty is put under direct vision through a bronchoscopy, which normally does my anesthesiologist. He uses it now routinely because it's so easy for him to do that, and it helps us a lot.
What size?
4 French, 3 French, whatever fits in.
All right, thank you.
Last question, please.
Just a quick question. So why 10 days for the contrast study? Why not earlier?
It's eminence, not evidence. So we always did it, also for open repairs, 10 days. I might go back to 7 days now because it proved to be safe. But yeah, 10 days was my, when I was implementing this technique into my new job position, I really don't want to risk something with compromising time levels or time ranges. So I did it again for 10 days. But you're right, 7 days should do the job.
I agree with Paul. You can get outside the box a little bit on that 10 days.
Last question, Dr. Akram.
Okay, thank you. Regarding the lung gap, you do an internal traction with just a simple suture in the upper pouch and another one the lower pouch. This does not cause any problems of leakage or tearing out or anything like this?
No, this does not provide any problems with leakage or something. I do not like the Fokker technique where you put it trans-thoracically or through the thoracic wall, because I've seen and reported cases on which were really dramatically complicated by this technique. So an internal traction suture is the same thing like Derek provided it will do perfectly.
Thank you, Philip. Now I'm concluding the session, and I will call the next session chairs, Dr. Ahmed Salim, Dr. Aydin Yamagurro, and Mohammed Al-Barbari, please. Okay, come in.